Thank you. Okay, so I'm presenting this work on behalf of my colleague, Anita Komlodi. Should be in the audience. There she is. And then my collaborators down at the University of Maryland School of Medicine, Katrina, Schrader, Mike Phipps, and Gruber-Baldini, Karen Yarbrough, and Lisa Shulman, all part of the neurology department down there. So we've been talking about self-tracking data. And we know that this is increasingly being used for chronic health care, and the potential there is really what are we going to do with all this data and how are we going to bring it into the clinical office visit? Well, really, I think we're all aware of the fact that there's this challenge for design and the use of self-tracking tools in how to design for this bridging moment when we bring it into the clinical decision-making process. And really trying to move beyond the rhetoric of simply being there to inform. As we've seen by our prior speaker, it might just be a lot more work, be seen as a lot more work for the clinicians. So this is really kind of an interesting problem, at least in the US-based system right now, because electronic health record providers such as Epic, which is one of the largest ones, are actually now supporting patients to upload certain self-tracking data through the patient portal. So they're allowing like the Withings and the Fitbits to start, patients to start uploading their data for their clinicians to be able to look at. And so there's this possibility for actually relating that information that is generated during the doctor's visits with the information that people have from their daily lives. And this opened up our question of, well, what practices and tools really need to be in place so that that self-tracking data can then be integrated and used in health decision making. So we talk about self-tracking data a lot, as the two talks that we've had in this session within the HCI and CSCW communities. We took a slightly different focus with this study. We really wanted to look at how people are talking and how people are engaging in actions surrounding the use of the data within the clinical realm, so a very conversation and interaction analysis method. And we went into it asking the question of not whether tracking data will actually be used in the clinical healthcare setting or if it has some measurable effect on health outcomes, but rather how is the presentation and shaping of self-tracking data enacted through talk and actions. So a lot of this work is actually a follow-on of prior work that we had done where we looked at supporting the co-construction of knowledge. And so if you went to my talk on Tuesday, you know what I'm talking about. So co-interpretation, the iterative and constructive data interpretation acts that are reliant on the alignment of shared perceptions between a clinician, a patient, and any lay caregivers that may be involved in this. So the study that we had done before utilized a number of sensors to look at Parkinson's patients' movement ability during, before and after deep brain stimulation. And then we presented the data on a tablet for everybody to look at and to engage with and co-interpret as to whether the DBS changes actually made a difference. We showed in that study that the changes that occurred in clinical co-interpretive practices, there were some benefits, such as the data presentation validated the patient's felt experience, and the clinicians used the data as prompts for the patients to further reflect and share their perceptions of their body. We did see some drawbacks, though. For instance, clinicians provided their own interpretation of the data before allowing the patients to form and articulate their perspective of the data. So these benefits and concerns are some of the things that we wanted to see if we could address with this follow-on study, particularly looking at self-tracking data, which is data that's collected outside of the clinic walls and in which the movements were not directly observed by the clinician. This study also came from this focus on understanding the work that's required to shape the data to engage in that co-construction of knowledge and shared decision-making. So in this paper, we're actually going to show how clinicians and patients don't simply kind of just look at the data, but they actually engage in a crafting of the view towards mutually agreed upon understanding. So by crafting, we're building on the work that I've done in the past with surgeons and how they use imaging, using it as a collaborative data usage process, as a deliberate execution on what view of the data is of importance to invoke a particular view of the body and actions on the body that need to be shared. So what we wanted to see is that the data is visualized and configured in such a way that it conforms to the needs of the collaborators, and thus playing an important role in the way that visualized data is discussed and acted upon. So interactions, actually, with the visualized data does not simply highlight data as much as actually produce a particular view of the data and thus a particular view of the body that the data is representative of. So we wanted to look at dialogue and actions enacted by both the clinicians as well as the patients and how they may have a shaping effect on what is attended to in the discussions around data visualizations and how the data is then interpreted. So what did we actually do here? So working with my colleagues down in the Department of Neurology at University Medical, Maryland Medical System, we did field work. So we did it in the neurology ambulatory center. So this is a clinical environment for patients to come in and meet with their neurologists. Typically, regular activity is discussed, but is not very substantial. So this is with Parkinson's patients who really greatly benefit from walking, but there's not much more than, are you walking? Because that's really good. Here's all the brochures that you should read about walking. And the problem is that this came out of some of our conversations with neurologists, that patients are not really aware of how little they're actually walking. I mean, we all fool ourselves too. The first time you get a Fitbit, you're like, ooh, that's not good. So this is very common. And up until now, patients were really not using self-tracking technologies. And if they were, they weren't bringing it into the appointment. So there was this interest in using self-tracking, and the clinicians wanted to see what happens if they saw the data. But up until this point, they really didn't have much experience. So this is really, a naive population that we were able to tap into. So we used the Fitbit Zip for a lot of reasons that I don't remember anymore. But the patients were able to keep this as a thank you. We had 9 patients that had Parkinson's disease, and then we also had 2 attending neurologists, so very experienced neurologists who specialized in Parkinson's disease, and were very interested in seeing what happens with this data. And the patients were recruited after the regularly scheduled clinic visits, so they were already coming in, and we said, hey, would you like to have be a part of this study where we'll give you this a Fitbit? And what we were asking them to do is to wear the activity monitor for 4 weeks, so to get, quite a nice amount of data. And they had the access to view their step count data on their personal tablet, their phone, their computer, however they wish to look at it. And then we also had the password in order to download the data. And then they were to come in for a 1-month follow-up office visit for 10 minutes. So we scheduled these for 10 minutes. Not 4. And I would like to say that we actually never ended up using the entire 10 minutes. I would say on average they were about 6 to 7 minutes. When the patients came in and they sat down with the neurologist, our research coordinator, we did this super lo-fi. We went with paper. We wanted to see what happened if we had a paper display that showed over the past 4 weeks an average daily step count per week, so week 1, 2, 3, and 4, and then the daily step totals for the last 28 days. So they could actually look at every day and see the ups and the downs of the total for that day. And then each of those colors are associated with one day on the right. We would bring the graphs in, lay them down between the clinician and the patient so that they can both look at it at the same time. And we actually brought in 2 so that if they wanted to, they could take 1 for each of them. So that was another thing that we wanted to see. Did people engage with their own individual graphs? So what happened? So here, let me give you a little bit of a story. The first thing we saw a lot of was a co-interpretation of the data outliers. It's the first thing that pops out at people. So this is what you see. You see the doctor leaning over the graphs and say, let's see here. Well, let's see if there's any pattern that we can see at all. It seems like on that one Saturday, you kind of took it a little easier maybe, but otherwise it was pretty consistent around 10,000, which is the recommendation. And the doctor starts pointing to the display with a pen and hovers over it. And then she says, wow, this is amazing. Here you reached 20,000 steps on one day. And the patient says, I know what day that was. And the doctor says, what was that? Patient says, we had a lot of deliveries that day, hospital beds and chairs. I delivered medical supplies. That one day there, we were pretty well swamped. And the doctor says, well, that's right. You're still working full-time, aren't you? What day do you think? And then she starts pointing to the weekly step count graph. Were the factors that made you less active maybe in the third and the fourth weeks? Was it just not as busy at work? And the patient says, not as busy, probably. That would almost have to be it. It was slow for a few days. It runs in spurts. Some weeks were really busy, and then other weeks were not really busy. It depends on what we're going to do. And she says, in your free time, unrelated to your work, how much physical activity do you do then? And the patient says, not a lot. And so this was really interesting, how the clinician used her pen, not to draw or anything, but just to use it as a mechanism to point, and to guide the review of the data by calling attention through both talk and action to first the daily step count and then the weekly step count. Along with the conversation around the significant highs and lows that were evident in the presented data, the patient was actually able to then contribute his knowledge towards specific moments of interpretation to provide a better understanding of his walking behavior in the context of his life. So what is really important here is that this guided use of co-interpretation of the data began to emerge for the clinician as well as the patient, and highlighted really a problem with the patient's activity level that might have been missed had they been simply discussing an average over the week or month. So after they looked at these outliers, then they started to build up a story about the trends. So here we see the doctor saying, well, let me look at the day-by-day graph. The one consistent thing that pops out to me is that and then she begins to point to each orange bar on the step count graph, which is the same day of the week. The orange bars are consistently even in recent weeks. I don't know about week 5 here, but in week 3, week 4, and week 2, they're in the low. They're the low, and that's Sunday. So Sunday was... And the patient says, I probably do less on Sunday. I might read a lot, you know. And the patient says, well, I mean, it's good to know that because here in the average, and then she points to the weekly step count, so even if we focused on days where you're low in order to try to focus on that. And the patient says, well, there, and she points to a weekly step count graph, and she says, are many days when I want to go out and walk, but when the medication wears off, it's like I'm a little shaky and my right foot kind of like drags, you know, and I'm like almost limping kind of. When I'm like that, there's not much I can do. I mean, I can do some things. And this is really important because the physician is thinking that she's finding something out about Sundays specifically. That's the data that she has in front of her. But it's the patient then who adds in this information that this isn't really about Sundays. The barrier here is her chronic illness and the fact that the medication is not having the effect that it needs. And that's something that she's struggling with on a regular basis. And this then led into a conversation about, well, maybe the medication's not working, maybe we should have a better discussion about that. This discussion never came up before this conversation. Why? I have no idea. So then the third thing that we saw was, and this is what we were hoping to do with this, is to come up with walking strategies for people, that they could go ahead and say, okay, what can I do to increase? So what we see here is the doctor saying, well, what would you say based on the fact that, I mean, your high day is obviously 10,000, and then she points to the daily step count graph, and your low day is between 2,000 and Sunday over here. What would you think would be a reasonable goal for you? And the patient says, steps? She says, yeah. And the patient says 7 or 8? 7? And the doctor says, 7 would be really good. I think that we should say 5, though. Pick a practical goal for you that you could really, like with the pain. And the patient says that, yeah, that I could achieve in the short. She says that you could really achieve. And this is when the patient really looks at the graphs and she says, well, then I think it should be 5. And the patient says 5, and the doctor says 5. And that's actually when she points to all the times that the patient was over 5, saying that I think you can do even more days over 5, and I think that would be achievable. In a lot of these situations, though, what we saw was the doctor engaging and interacting with the graph, and only occasionally the patient sort of pointing or maybe like flicking their hand in the direction of the graphs. And then you see a lot more of the patient talking. We had one situation where a patient was very, very motivated to do a lot of steps. And she originally was thinking that her goal should be 15,000 steps. Remember, she has Parkinson's disease. I don't even get 10,000, so I was impressed. But what's really interesting is when this conversation was, well, what's actually practical? This is our one example of her picking up the graph and really looking at it and taking a close look and identifying for herself what is an achievable goal. And we think that's really interesting, and yet at the same time, it was disheartening that we didn't see this with our other patients. So then we come back to the problem of what does this all mean? So the first thing is that we did see what we expected, which is a crafting of the view through both talk and actions. So people, particularly the clinicians, turn the data into a resource to collaboratively identify health strategies and goals. So that is the difference really between simply looking at the data and one of co-construction of the data. However, as I mentioned, we saw this unequal distribution of crafting. So for patients, we really saw this missed opportunity to share their lived experiences, really to explain the data, to take the data up themselves, and to sort of own it. On the side of the clinicians, they did a lot of crafting, mainly involving talk around the data and the physical actions to bring into focus what they saw in the data. But what we were hoping is that that was a moment where the physicians would bring in their experience, especially after they had seen so many patients by the end of the study. What is normal? What does the AMA say? What do we actually know about the ability of Parkinson's? We were hoping to see a lot more of that expertise being brought in and something that they have that the patients usually don't have. So the question is, should we encourage patients or clinicians to first view the data alone? And that's actually maybe not the best idea either, because there are some studies that show that when neurologists look at data, they really don't do more than just identify the outliers. They're really unable to really understand what's the trend behind it. And then when patients look at the data alone, they tend to draw incorrect conclusions from the data, which then they could have some bad decisions with regards to their own health. So we know that this is the same problem that we saw before. We thought that the self-tracking data source would have a more equalizing effect. We clearly see that there's a need for intervention that allows patients to really craft the view of the data along with their clinician. And so this is where we come to what are some of the tool implications that we think we would want to try out next. So the first thing that we came up with was an annotation capability. So we saw a lot of the pointing and annotating were common actions taken up by both the clinician and the patient. We thought perhaps providing a digital pen for annotation and pointing allows for the display of these gestures on the graph, as well as capture and later review of these gestures. For instance, a patient could review what was circled or pointed to, or where the line was drawn across the graph when they returned home. Likewise, at the next follow-up visit, the clinician could review what they focused on last time and use those annotations to help craft a view of the newly collected data. But actually, in the process of putting together this talk, and I was looking for examples of pictures on the internet of how tablets were integrated into the clinical environment, I tended to see the same picture over and kind of over again, where the person holding the tablet is always the clinician, and they're showing the data to the patient. So obviously, we're already aware that this is kind of the predominant model. And so one of the things that we thought of is we've got to stop this one tablet display design. And I can't believe, coming from the CSCW community myself, didn't think of this ahead of time, that really we need to capitalize on what we already know about people having individual displays and how that allows for somebody to own their own data and to interact with it and sort of form their own understanding in the moment of a collaborative environment. And so what we would actually like to try in the future is what happens if the patient has their own tablet, the physician has their own tablet, and any of the annotations that you do on one tablet could then possibly be shared and pushed over to the other tablet, thus really building up on the work that we have as a community and a very well done body of work as well. And the other thing, compared to some of the other work as well, is we also were, with this study, investigating some of the different ways that we can present the data and how that was perceived by our patient population, who we did do various levels of mental cognitive ability, because Parkinson's disease also has a problem. It affects cognitive impairment as well. So we'll be presenting on that data as well, so you can look forward to that, because we think that that makes a big difference with regards to how much people want to take up their data. So thank you. I'd like to thank my colleague and all of my colleagues at the School of Medicine.
We have time for one or two questions.
One very quick question, apparently.
I'm Bernd Prohler from Queensland University of Technology in Australia. Really interesting talk, and a lot of things you presented I'm grappling with as well. In particular, I guess my question is, do you see people to bring in their experience
at the same time, that then allows that conversation to happen as well a little bit further. So to get neurologists to agree that that's a good idea, you got to go slowly. But thank you. Yes, I agree with that.
Very quick question. Very quick.
Max.
Hi, great talk. Thanks. I'm Max from Oxford. I was just wondering, in some of our things we have people struggling to express, a patient struggling to express something, and using the data to communicate something that they can't put into words. Did you see any of that? I was wondering.
Yeah, absolutely. So pain was a really big aspect of that. So being able to see, you know what, one of the things that might be the aspect here is that I'm in a lot of pain. And then they had to talk about what is the type of pain and why does it come up and is there a pattern to that pain? And you know that they hadn't been thinking about this before, which is a good thing to have that conversation. So it goes back to that patient who really hadn't brought up the fact that the medication wasn't working all the time. So yeah, that was the one thing that we want to see more of, actually.